our moderators for the first session are Dr. Khanh, Nguyen, and Dr. Morrison. And I'm going to turn the meeting over to them to introduce our first speaker. Thank you.
Thanks very much, Peter. So the first speaker came to us all the way from New York by train, I understand. His name is Steve Elias. He's a good friend and very, very knowledgeable about technologies. So he's going to talk to us on how many of these technologies we need to improve the superficial venous care and what are on the horizon. Steve?
Okay, thank you. And it's happy to be here. Know a lot of you and seen a lot of you at many other meetings, but this meeting keeps getting bigger and I'm glad for everybody. So my charge was to talk to you really about what's new coming up on the horizon. Then just at the end, I'll tell you maybe what else do we need, although it's going to be involving sclerotherapy, and that's going to be the whole next segment of this. All right, so I'm going to talk to you a little bit about emerging technologies in superficial vein disease. And I'm going to speak to you really about three of these emerging technologies. Is chemical ablation, which is sclerosafe, HIFU, high intensity focused ultrasound, trade name is Sonovane, and there's also thermal imaging. And I want just to let you know for the full disclosure, I do work with all of the companies that are making these devices, and we'll actually be doing some clinical trials with two of the three of them. So sclerosafe, what is it? Well, it's a non-thermal, non-tumescent technology. There's a proprietary dual syringe system, which I'm going to show you. One syringe aspirates blood as you infuse a sclerosant. So essentially you're injecting sclerosant into a collapsed vein, as rather a vein that's filled with blood. It's not FDA approved yet, although they're just about done. This is one of the companies I work with. And they're just about done with their FDA approving them for their clinical trial that will start in the US, but it does have a CE mark in Europe and Israel. So it's a 5 French catheter. You access with a micropuncture and then an 018 wire. You pass up the 018 wire. You don't need to upsize, and the catheter itself fits right over the wire. The pullback rate is really the same as laser or MOCA, and I'll show you a little video of it. Basically, every 5 centimeters, you're giving about a milliliter of foam sclerosant. This is a device. You can see there's this dual syringe system, and as you inject with the smaller syringe that's going to have the sclerosant in it, the larger syringe is aspirating the blood prior to injecting into the veins. So again, with all the other procedures we do, we elevate leg, we want to empty the vein, we put tumescence, etc. This is doing it internally by aspirating the blood. And this is what it looks like. I actually did a couple of cases over in Germany with Ralph Kolvenbach. And you can see here, it's really just a nice slow pullback as you inject, and the other syringe is aspirating the blood. And different lengths, because you can do short segments, multiple segments, and obviously longer segments. So you can go retrograde, which is very nice. We all know going retrograde with non-thermal, non-tumescent is really a nice way to take care of advanced disease. Here, though, you can go retrograde and you will foam not just the, say, the below knee grate or the small saphenous, but you'll also get foam into those tributaries that are in the peri-ulcer area. And Ralph Kolvenbach, this data actually has been published now. He treated 70 patients. This was physician-made foam, although it's extremely intriguing to me to use Varithena with this as well. And all of them were included at short follow-up. That short follow-up was a total of 1 year, but more importantly, there's only 2 cases of phlebitis, and there were no nervous skin injury, obviously, because it's a non-thermal, non-tumescent. We did publish something out of Israel utilizing MOCA and sclerosafe for patients with ulcers. And those people who were not healing when something was done, at 3 months, 97% of them were healing. And at 6 months, there was only 1 recanalization. So it appears, it's an option. So in conclusion, you can use this not just for the axial veins, but if there's a superficial, varicose vein that's relatively straight and you get the catheter up it, it's good as well. It's short learning curve because it's already what you've been doing in terms of access and pullback, but there's no long-term results. What next? Sonovane, which is what I call, a Star Trek kind of thing. This is a device that you're going to be able to treat venous disease without making any incisions or ultimately any needle sticks either. It's transcutaneous. And a lot of these slides are courtesy of Alfred Obermeyer. This is the device. Right now it's actually generation 2. This is generation 1. It's large. I mean, not so large, but it's not like a tiny little thing. But the main thing is this working unit all on your right. We do not have a pointer here. So this mouse works? Yep. All right, good. If we can get it over here, no, it's not moving to the other screen. It doesn't matter. All right, so anyhow, I'll give you the visualization unit. There's 2 ultrasounds. One ultrasound visualizes your target tissue, and the high intensity focused ultrasound focuses the high intensity ultrasound into the area you want to destroy, and the temperature goes up to about 85 degrees Celsius in that area. So this is the working unit here, and you can focally heat areas. So you think of you're going to be spot welding your vein or your tissue. And this shows you before and after you, the unit has a computer in it, and you aim where you want to be, you visualize. And this has been used many years for benign breast lesions and also benign thyroid lesions. And now using it for veins. This is Alfred Obermeyer doing the procedure. Patient lies flat. You visualize your target vein and put a little bit of compression to partially collapse the vein, and then the machine does its thing. And he did do 64 legs, mostly were recurrent or an advanced disease. And you can see things really did well. In terms of where I think that fits in, it's recurrent veins, neovascularization up in the groin. Perforate is really, really nice for. Do a whole long saphenous vein at this point, it's going to take quite a while. But technology gets better over time. But the idea is really neat. Originally, this was done with generation 1. So some people needed some tumescence because the length of heating was long. Now it's down to less than a second. So the short burst, people can tolerate it without needing any anesthesia at all. Actually went over to Vienna in mid-January to see some of these cases again, because we're going to be starting the first clinical trial in the Americas back in Englewood Hospital in May with this. But there were minimal side effects and no skin burns, because again, this is going below the skin. You're focusing below the skin. You don't have to go through the skin to heat it up. It's really nice here, neovascularization with a refluxing stump. You can see on the right side that you visualize these veins, and then you treat them, and you treat them sequentially. You treat the length of the vein, and you can see over the pictures as day 3, and then you can see on month 3 how things really look quite different. Really good for, as I think, perforators. It's really going to be nice. It's just you isolating 1 or 2 shots on that perforating vein. And this is a 95-year-old that had ulcer, and that ulcer ultimately healed. This is Alfred Obermeyer's patient. So there are advantages here. It's focus heating. You don't need any sterile field. You can treat over skin that's damaged. You can treat tortuous structures. It doesn't really matter. And thus far, it really appears safe. And they've have over 1,000 patients now. There's 3 other sites outside of Alfred's site over in Europe, and 1 in Asia. It takes a long time right now. Average case time is at least 45 minutes to an hour. And if structures are very close to the skin, you may need tumescence to kind of push them down. But things will get better, and we never dismiss technology just because we don't think it's working first generation. So how about thermal imaging? I know Sanjeev has looked at this and interested in it. Where does thermal imaging fit in? Well, this is a diagnostic tool. We all know thermal imaging, how you can get these nice pictures of what's hot and what's cold on the skin. It detects a difference in surface temperature. So it doesn't detect the exact temperature. It detects a 1 degree difference. Now, and it's been used in many conditions, peripheral artery disease, obviously Raynaud's disease, et cetera. But in venous disease, you can see the varicosities because you're only looking at a temperature difference, and varicosities tend to connect to the deeper veins, and that temperature difference is different than the surrounding skin. So here you can see a normal picture here. Everything looks the same. Patients with some reflux and varicosities, you can see the varicosities. This is the device. It's going to look better. It's going to get a little bit smaller. But what's nice is it takes a picture of the patient's legs simultaneously with the thermal image, and you can see where the venous disease is. This does have some pretty good predictive value, both positive and negative. Ari Sofer, down in Florida, he's helped to develop this with David Wright of the Varithena fame, and they published this in the Vascular Disease Management. Basically, there were minimal false negatives when they correlated with ultrasound, and there were really minimal false positives as well. So it's very good. Patient comes into the office, you don't see many veins, they have symptoms, you do this over their leg, you don't see anything, and you didn't think their history made it, you don't have to waste your time doing an ultrasound, or vice versa. If you have a patient that comes in and it's not all that obvious, you take the picture and you can see the great saphenous as well as the varicosities, and this can help the ultrasonographer focus on what's needed, especially here. Routinely, these veins are not imaged on a routine ultrasound exam, but if you have this picture beforehand, you can point to your ultrasonographer and say, here, take a look in this area as well. You can see the feeding reticular veins into spider veins, and it also works through compression stockings, because again, it is just looking for temperature difference. And with ulcers, we're really looking at this pretty well. This can be a screening tool in wound clinics, and then identify the problem and send them to you or us to be taken care of. So it's really good for both positive and negative screening. It's also helpful for patient education, show them the extent of their disease. What's nice is post-treatment, the images normalize. So you can document. You don't necessarily have to do another post-procedure ultrasound. You can just document that you've improved and that the image that you had before, those veins are gone. It interacts with the EMRs, and you store all these images in the cloud as well. So these are my words to live by, always in venous disease, and I think in life in general. So when we hear new technologies, do not dismiss them out of hand. See where they're going to go and work with it. So you always need to think young and think new. This is why they only let adults in the playground and with children when they are there. Thank you.
Thank you, Steve. I'll tell you, there's nobody in the country who knows more about what's coming than Steve does, so pay attention. I'm going to go ahead and give my talk if it comes up. We're going to talk about VenaSeal first. So I am going to talk about VenaSeal, the long-term results. That is Colorado River. That's my disclosure side, but it's the Colorado River, upriver of Grand Canyon, place called Horseshoe Bend. So we know that the cyanoacrylate VenaSeal system is intended for use for permanent closure of veins. Incompetent saphenous veins, veins from 3 to 20 or perhaps higher millimeters in diameter, perhaps for incompetent perforators, tributaries, and epiphyseal veins, but that's a little early. This is the system. It is a non-thermal, non-tumescent, non-sclerosant therapy. Doesn't require tumescent anesthesia. There's no risk of thermal injury. You don't need a compression hose. There has been quite a number of clinical trials with VenaSeal. The first one was a feasibility study by Jose Almeida. We now have 3-year results. Next one was Tom Propsel's European trial, and then finally the FDA trial, VCLOS trial. We enrolled 242 patients in that trial. This was a non-inferiority comparing RF to VenaSeal. It was not powered to identify superiority. So that is the VCLOS trial. The next trial was Kathy Gibson's trial, WAVES, where she treated patients, about 50 patients who were larger in size, and she didn't use compression hose. In the FDA trial, we were required to do compression hose because it was for RF. We were comparing it to RF. This trial, they did not use compression hose. That's back to our trial. Primary endpoint for the VCLOS trial was complete closure of the target vein at 3 months. Secondary endpoints were intraoperative pain and ecchymosis. We also looked at any changes in the VCSS scores, the SEEB classification, Aberdeen scores, and Euroqual 5D scores, as well as adverse events. Those are the sites for enrollment. And this is the algorithm, 242 patients. The first 2 in each center, each of the 10 centers, were used as roll-ins, and we kept track of those as well, but there were 222 who were actually followed. And that is the down below is the 3-year data. You can see VenaSeal was 94.4% occlusion and RFA 91.9. So that clearly establishes non-inferiority of the VenaSeal compared to RF. Ecchymosis at day 3 was a little bit more with the closure fast, as you would expect. You need tumescent anesthesia for the closure fast, and you don't need it for a VenaSeal. So in summary, this is a method of closure suggesting non-inferiority to RFA. The closure is very high. Closure rate is very high. It's safe, doesn't require post-procedure compression stockings. And we'll go on next to 60 months. These are the 60-month, same essentially. We had told patients it was going to be a 36-month time period. We decided to carry it out 5 years, and trying to get those patients to come back was a little bit difficult, but we got 89 patients who did come back. Kaplan-Meier analysis at 5 years shows essentially the same for RF and VenaSeal. And VTCS scores improved, as did the Aberdeen scores and the Euroqual 5D scores, all improved pretty much equally with both groups. This is interesting. So we started out, we didn't enroll any C0s or C1 patients, and we had about 18 patients in the group that were C3 to C4B. At the conclusion, we had quite a number of C0s and C1s, and a much smaller group. Although the overall group was smaller, but there were fewer percentage-wise, fewer C3 to C4B patients. Pretty much everyone is satisfied with the treatment. And adverse events did not occur between 36 and 60 months that we wondered whether this was going to be long-term durability and safety, and there weren't any serious adverse events, PEs, DVTs, or problems between 36 and 60 months. A few patients needed some sclerotherapy in both groups. So in conclusion, this is the first ever 60-month data. Both systems had demonstrated sustained improvement in disease-specific and other quality of life scores and no serious side effects. That is Antelope Canyon up in the northern part of Arizona, just a spectacular place, as you can see. So there were some complications. I want to talk about these briefly. There's some phlebitis issues. Within the trial, we were required by the FDA to call all inflammation phlebitis. Most of these were not phlebitis. This was inflammation in the tissue and subcutaneous tissue, not necessarily in the vein itself. And there were some hypersensitivity reactions to the VenaSeal. So this is something called phlebitis-like abnormal reaction, or PLAR, posited by some Asians. 15 to 25%. It's usually self-limiting, includes itching and erythema and swelling, handled pretty well with NSAIDs, and most of them resolve on their own. There was one granulomatous formation with Turkish glue. The other glues in the rest of the world are far less viscous than the VenaSeal, and so migration is a potential problem. This is a report on the developer of this system, who agreed to have his vein explanted, and they took a look at it and found that in fact it was a permanent implant. The VenaSeal could still be identified there. Follow-up treatment, phlebectomy and sclerotherapy. This is a paper from Asia also. Fewer patients required adjunctive treatment than was expected. In Kathy's paper, 65% did require something. So a full third of them didn't require anything at all when she thought they were going to. Monument Valley up in northern Arizona. There's some other VenaSeal trials. This one is Kathy's. That's that 50 patient trial with larger veins up to 20 millimeters in size, and no compression hose. All of them closed. Closure rates at 99% at 3 months, significant improvement of quality of life, and the need for other concomitant procedures was markedly decreased. 3-year trial. This is the Jose Almeida's trial. So this is first in human, 94% occlusion rate by Kaplan-Meier analysis. And this one is from a Chinese group. They had about 78% occlusion rate. That's a little bit lower than most reports, but it's still good. This was a paper looking at occlusion rates of perforators, and they got a perforator occlusion rate at 3 months of about 76%. That's about what you see with thermal ablation, primarily because of the technical aspects. There are some drawbacks to perforators. Treating perforators with thermal ablation, as you know, there's a potential for nerve injury, fistulae, pain, and technical success is tough. But this is, again, Kathy Gibson's work, 56 perforator patients done in combination with a truncal vein. And essentially, she found that very high closure rate of 85%, and that's great compared to a thermal, which is a little bit lower than that. She essentially had no complications. This is her procedure. So she uses a little bit of local anesthetic, puts a 21 gauge needle into the perforator, and then, perforator just above the fascia, and then slowly drips in the VenaSeal. You can see it. It's very viscous, so it doesn't travel much at all. It pretty much stays where it's supposed to. And those are the images before and after with a closed perforator vein. In the UK, they tried to treat an anticoagulated patient and it wasn't successful. That's not been our experience. Most of the time, these will close fairly readily. There have been some other cyanoacrylate trials, and I'm going to go through them very quickly. They're mostly Turkish glue. And it's it has a viscosity of water. They do get good results that are reported. There's some Indian glue. They get good results. Russian glue. Everybody's in the game. So this is a meta-analysis, 15 articles, about 90% occlusion rate with the adhesive. Another Turkish glue, comparing it to laser, shorter period time to do it. Another one comparing it to laser, short period of time, not much ecchymosis. So the biggest advantage compared to foam sclerotherapy is it really is much more effective and it doesn't require a compression hose. The disadvantage, of course, is the cost. And a potential disadvantage is that it's a permanent implant. And I tell all my patients, this is a permanent implant. If the idea bothers you, don't have this procedure. And if also they're an allergic person who has lots of allergies or some sort of disorder, don't use it. So anyway, it is safe. Cyanoacrylate is safe, reduced need for adjunctive treatment. Careful technique will avoid most of those infectious problems, and use of peri-procedural insights will help. Thank you very much. Next, we're going to have Zoe Deol. Zoe is right behind me. Zoe's going to talk to us about an anterior accessory saphenous vein in insurance coverages and clinical data. This is something that we all are curious about. Zoe.
All right, so the AAGSV usually joins the GSV very near the saphenofemoral junction. It can drain directly into the femoral vein. It can also drain below the saphenofemoral junction and sometimes even into the external pudendal vein, which, if it communicates with the ovarian vein, can be responsible for some of those anterior thigh varicosities that we see with pelvic vein disease. It is not a tributary. It's got a media similar to the GSV in that it's very thick. It usually travels in its own fascial sheath, parallel and external to the GSV. When it's insufficient, it tries to go anterior thigh and lateral leg and drain into a perforator at the lateral knee, but it can actually travel all the way down the leg and drain into a medial lower leg perforator. So what is the difference between the AAGSV and the GSV? We have a lot of studies out there that we see about the efficacy of treatment for GSV disease, but not as many when it comes to the AAGSV, until Marlin Schul came along and published in 2020 using the AVLS Pro Venous registry data. He demonstrated that yes, AAGSV disease is less common than GSV disease, and the severities tend to be less with AAGSV. However, there is a higher incidence of superficial thrombophlebitis associated with AAGSV disease. Now, looking at insurance coverage, this is just a little smattering also from Marlin's paper, where there are 5 insurances. And because of our lack of data, we don't have any solid coverage policies across the board. Of these 5, 3 of them require that you treat either the GSV or the SSV prior to or at the same time as the AAGSV, which obviously is a problem if they aren't refluxing. One of these does not cover AAGSV at all, and only one of them, the Anthem policy, does cover AAGSV as a primary disease. Now, we do also have appropriate use criteria. This was published in 2020, a collaborative effort between the AVLS, the AVS, and the SBS, where they came up with criteria that is appropriate to treat for AAGSV disease. It is always appropriate to treat when there is a refluxing AAGSV in SEEP classes 2 and class 4 through 6. When the refluxing AAGSV is directly related to the area of concern for the patient. It may be appropriate to treat symptomatic patients in C3 disease, and it is rarely appropriate to treat asymptomatic patients with visible varicose veins or C2 disease, or also patients that have refluxing GSV in either C2 all the way through C6, but no refluxing AAGSV. So sometimes there's discussion of patients that develop AAG reflux after the GSV is ablated. It is never appropriate to treat non-refluxing, non-symptomatic AAGSVs. Now, our paper that we published in August of 21 in the JVS VLD, we decided, Marlin pointed out the differences in the clinical appearances or the SEEP classes for these two. So we wanted to look at the differences in treatment outcomes. We decided to isolated AAGSV disease and isolated GSV disease and compare the treatment outcomes of those two, looking at ablation alone versus ablation and phlebectomy. As Marlin pointed out, if the morbidity comes from the varicose veins, then treating those tributaries is going to be important. And our hypothesis, again, was that if that's the cause of the superficial thrombophlebitis, doing ablation alone is not going to be enough. And as you know, some insurances such as Anthem requires that you wait at least 6 weeks prior to treating any tributaries. And that may or may not be appropriate. So here are the results of our study. Before I get into that, I'm just going to show you 2 of my patients here. The female on the left, she's G4P4, she's SEEP class 2, CVQ20 of 52. And the patient on the right, he's male, he's a Delta baggage handler, so we need to make sure he gets to work on time. And he's SEEP class 3 with a CVQ of 78. Which one suffers from AAGSV disease? So we'll look at that later at the end. And we looked at the, as far as treatment outcomes, we compared RVCSS and CVQ. So we looked at severity and quality of life. We also looked at surgical comorbidities, SEEP, BMI, gender, race, and the average number of procedures performed. Totally, we looked between 2015 and 2018, 31,000 patients and 49,000 limbs. And of those, only 91 patients and 103 limbs had isolated AAGSV disease. So yes, it is less common as compared to the 7,000 patients and 10,000 limbs with GSV disease. Both had a high percentage of females, as would be expected, and there were no statistically significant differences in pre-intervention RVCSS scores between the two. Now here is on the right, you'll see ablation alone, the RVCSS scores. On the red bar, that is the pre-intervention. The green bar is 1 month and the orange bar is 6 months. So there really isn't very much difference as far as clinical severity between the two and the success of treatment outcomes. However, on the left, when you look at the gray, the quality of life, there is improvement with ablation alone in both groups at 1 month, but at 6 months, those patients with AAGSV disease, their CVQ20 score went back up and was not statistically significantly different than the pre-intervention scores of the GSV patients. So that tells us something right there. Now, you add phlebectomy. When you add phlebectomy, again, the RVCSS scores or the severity scores are similar between the two groups, but this time the 6-month quality of life score remained improved. So when you think about the RVCSS score, there's only 2 questions on there that would relate to those tributaries and thrombophlebitis, and that would be pain and varicose veins. So it makes sense or stands to reason why the RVCSS scores appear improved, but the patient's quality of life may not. Therefore, the conclusions, yes, AAGSV reflux, it typically is associated with C2 disease, whereas GSV, SSV, and perforators are more commonly associated with C3 through C6 disease, and that treatments for the 2 types of disease may be different. Now, looking back at a previous study in 2009, Thiva Kumar, he showed that thermal ablation alone of primary AAGSV disease resulted in successful abolition of the reflux, but 61% of those patients required additional sclerotherapy to treat the varicose veins after. So looking at Anthem's policy of waiting 6 weeks, you might save 40% of those patients from needing additional treatment, but most of them will come back and require treatment. In summary, yes, we looked at ablations and phlebectomies. We did not look at sclerotherapy. That is a future study that we're going to look at, and also varithena. But we definitely are seeing some differences in disease and treatment outcomes. So back to this picture, which one of these patients has AAGSV disease? How many people here think it's patient number 1? How many think it's patient number 2? How many think it's both? Very good. So the patient on the right, the female, she's got your classic AAGSV disease. The patient on the left, he's one of those patients. He had a 13 millimeter AAGSV. His GSV was 3. And that tributary drained all the way down his anterior thigh to the medial and into a distal calf perforator, very large distal calf perforator. So you can be fooled. Now, here's just a little bit of spoiler alert for our future research, always pushing that. We decided, is there a difference between above knee and below knee disease? And if you look at the preliminary data on the left, this is comparing C2 disease in the blue bars to C5-6 disease in the orange bars. On the left, it's with junctional reflux. On the right, it's without junctional reflux. And I don't have a pointer, I don't think, on here, but what we're seeing is that when you have patients that have junction all the way to distal calf disease, these are more commonly C5-6 patients. Patients that have strictly above knee disease in those segments tend to be C2 patients. And patients with 100% below knee disease tend to be C5-6 patients. So we are seeing some differences in reflux patterns. We're also still collating our data from this. So that will be maybe next year's talk. And that's it.
Thank you very much, Zoe. Next up, Ken Nguyen is going to talk about the review of literature from 2020 and 21 and the impact of those investigations.
Yeah, like Nick said, I've got the privilege of giving the year in review in about 10 minutes or so. So I'm going to try my best to get through this. So, it's really tough to talk about the last year without bringing up the 2 biggest topics, COVID and the Medicare reimbursement cuts. I'm sure that everyone in this room has really dealt with all 5 of these things: fear, shutdowns, staffing, new protocols, supplies. We're still dealing with some of that. I'm sure everybody else is as well. And that's reflected in the literature. The top 5 most read articles published in AVLS are all related to COVID. However, life does go on. And if you do a search for over the last 10 years, you will find that anything related to varicose veins or venous insufficiency, you'll find 2,000 articles, 743 peer-reviewed publications, 60 randomized control trials, and 29 systematic reviews. But if you do the same search over the last 12 months, you'll find that there's 90 peer-reviewed publications, 11 randomized control trials, and 8 systematic reviews. So it's been a very, very busy year. And you can almost say that the pandemic has been very good for research. And as I was preparing for my talk, it was actually very difficult to find or actually choose the articles just because there were so many good ones out there. So the first paper is, and Marlin's going to be quoted quite a bit here today, but first paper is regarding private payers. So this paper was written by Howard Welsh and our very own Marlin Schul. They looked at 7 commercial payers, and they didn't just really discriminate, say all the bad things about them, but they also pointed out all the good things as well. And the best thing about the paper was that they actually gave a solution. They formulated a proposal, and this was the very first time that anybody's ever done that. And there have been at least 2 payers out west that have actually made some adjustments. And Marlin tells me that he's got an appointment with the Chief Medical Officer for Anthem on April 11th. So hopefully this is going to bring some significant change for us. 2021 was also a very important year for lipedema. And like Dr. Herbst said this morning, as she presented this morning, lipedema finally got the attention that it deserves. As we all know, I think that Dr. Herbst did a much better job than I will, but it's a nodular fibrous disease of the adipose tissue that affects mostly women. It goes into the hips, buttocks, and legs, and sometimes can be so painful that patients have trouble walking. The standards of care finally were given for the disease process, and 85 consensus statements were given. They described the history, the signs, the physical exam, as well as the comorbid conditions, staged them, and then gave the recommendations, which were based upon strength according to the grade system. Like lipedema, pelvic venous disorders also gained a lot of notice this year as well. But the progress in the field has barely been hindered by the lack of a good classification system that was accurate and reliable. And thus the SVP system was developed by Mark Meisner et al. So here they felt that every disease process, the signs, symptoms, and pathophysiology can be broken down into the different zones. So the first zone is based upon the top, which is the left renal vein, and it goes down into descending order down to the fourth zone, which is the deep venous and superficial veins. The SEEP classification takes care of the fourth zone, whereas the first 3 are taken care of by the SVP system. Signs and symptoms are broken down. Actually, symptoms are broken down by S1, S2, S3 based upon the location of the symptoms. Varices are broken down based upon location as well, V1, V2, V3. And pathophysiology is broken down by anatomy, hemodynamics, and then etiology. So for an example, a patient with pelvic congestion syndrome with chronic pelvic pain due to bilateral ovarian reflux would be graded as S2, V2, P subscript B, G, V, R, and T. So S2 is where the symptoms would be, which is the pelvis. The varicose veins would be V2, which is the location in the pelvis as well. Pathophysiology is bilateral gonadal veins. R is the reflux, and then NT for non-thrombotic. I wanted to talk a little bit about something new on the horizon that somebody may not be familiar with, but we all know the complications that are associated with IVC filters and obviously the need for removal. And so there was a recent preclinical absorbable filter that they looked at. So this is a review of 8 studies, 5 in vivo, 3 in vitro. And they described what the perfect IVC filter would be. It would be a filter that would capture the thrombus, it would let it absorb, and then it would dissolve over 35 days. They looked at 8 different designs, and they found that they were all very good in vivo and in vitro, and the evidence was actually quite positive. However, none of them were clinical trials. So there's a lot of work that still needs to be done here, and there's definitely some questions that need to be answered, which is the filter going to fragment and embolize to the heart? And then there's going to be some patients that will require protection for more than 35 days, but this is more to come in the future. What about patients that thrombose after iliac stenting? So, we see this all the time. We do a lot of patients with pelvic congestion and iliac lesions, and they do very, very well. But there are some patients that don't do very well. And Bill Marston has a very nice retrospective study, which looked at what are the variables that account for a patient that will clot early on. And what he found was that patients with more extensive disease, class 3, 4, multi-level obstructions, and patients with a hypercoagulable state are definitely have a 25% increased risk of clotting early on. And then he also found, though, that patients with anticoagulation with Lovenox for more than 10 days after stenting have a much decreased risk of clotting. And their recommendation is that for patients that are in this high risk, I know that Peter says, hey, these patients don't need, not these patients, but patients that are low risk don't need any anticoagulation. But patients that are high risk, we may consider that they need to be on anticoagulation with Lovenox for at least 3 to 4 weeks after stenting prior to starting them on a factor 10A. Another very controversial paper, Arjun Jayaraj, looked at 480 patients, and patients that wind up undergoing IVUS diagnosis. We use a very arbitrary criteria for deciding whether or not has a lesion or not, and he found that there's really no correlation between a patient that has quality of life measures as well as SEEP scores. There's no correlation between their clinical presentation and the IVUS criteria for stenting. So they felt that for a patient that has undergone conservative therapy, who has failed and still warrants significant symptoms, signs and symptoms, that there should be consideration for possibly treating these patients, even if their IVUS criteria is less than 50%. Another paper that's very controversial, led by our very own team. So pelvic insufficiency led for iliac vein stenosis and ovarian vein reflux treated with iliac vein stenting alone. So it's been pretty well established that 56% of patients that present with pelvic congestion will have combined iliac vein stenosis as well as ovarian vein reflux. Gaurav Lakhampal and his team looked at what are the chances of these patients getting better with only iliac vein stenting. And he found that 76% of those patients resolved without embolizing the ovarian vein. And their recommendation is that for these patients, it's better to go ahead and stage it and stent the iliac vein first, and then wait to see if those patients wind up needing embolization. Another paper that we did not expect to get a lot of attention, but wound up getting a lot of attention, was the fact that iliac vein stenting is safe if performed in an office-based laboratory setting. So 12,000 iliac vein stents placed in 1,100 patients. Minor complications were noted in 7.36%. All of those were site bleeding, access site hematomas, and then major complications, one each of allergic reaction, atrial fib, SVT, chest pain, and acute stent occlusion. That came out at 0.41%. So it's not the fact that this was safe that we found, but the fact that the QA process was so strong. And that's really what's been cited in this study as being so important. So really worthwhile to look at that as well. What about sclerotherapy? We recommend sclerotherapy. What about compression in sclerotherapy? We recommend compression all the time. And what's the data behind what type of compression, how long you wear it, what is the duration and strength of the compression? All of that is actually reviewed in this post-sclerotherapy compression paper, which is a systematic review of 9 studies. And they looked at the type, the duration, how long you wear it, how strong it is. And they found that for C1 patients, any duration of compression is going to be better than none. Okay. And then for C2 to C6 patients, those patients, the duration didn't matter. So as long as you put them in compression, there was no difference between how long you were, whether it was 1 day or whether it was 6 weeks. And then for patients with C2 disease, compression was better than bandages. And the higher the compression in terms of 20 to 30 compression was better than lower compression in terms of resolution of superficial vein symptoms. Nick already brought up the 5-year extension for cyanoacrylate. They found that there was no difference in terms of outcomes for radiofrequency versus cyanoacrylate. Not to be outdone, Varithena also has its studies, and one of our doctors, Pamela Kim, along with Steve Elias actually as well, published the results of polydocanol endovenous microfoam in clinical practice. So all of the previous papers for Varithena have always been based upon signs and symptoms and resolution of those. This paper actually looked at the closure rates and the effectiveness in the use of Varithena. So they found that 93% of patients at 3 months and 6 months had closure, and then they had significant improvement in BCSS scores. And a very good complication rate. I spoke with Pamela Kim actually prior to this. Unfortunately, she's not here today because she's giving birth soon. But she said that there was one DVT, and the reason why that happened was because they just didn't recognize the perforator. So if there's anything that I got out of this, it's the fact that Varithena is very effective, but also requires a lot of skill in terms of making sure that you're finding all those perforators. Varithena also had its 3-year data for the VANISH2 trials as well. And what they found here was that there really no significant difference at 2 years, 3 years for Varithena, and continued resolution of their symptoms. Assessment scores at baseline, and then at 2 years and 3 years, you can see that they came down pretty nicely. So, same thing with the VFI SIMQ symptoms as well. Baseline coming down, and then 2 years and 3 years staying pretty stable. What about the EVRA trial? So long-term clinical and cost effectiveness of early endovenous ablation and venous ulcerations. Here they looked at patients that were placed in compression, as well as treating the ulcer early on with venous ablations versus a delayed approach. And they found that these patients did much better if they were treated early on. Now, the recurrence rate was the same. I'm sorry, the recurrence rate was much lower, but the time to recurrence was the same. And in fact, about a third of the patients would have less risk of recurrence if they were treated earlier. And the cost effectiveness of the treatment was much less if you treated these patients early on. Also, the ulcers actually healed much quicker as well if you treated that early, which makes sense. And then let's talk about the final paper, which is the Extended Center for Vein Restoration Study. So for the Center for Vein Restoration Study based upon outcomes for treatment of chronic venous insufficiency in Medicare and non-Medicare eligible patients. This is the largest paper to date in terms of looking at Medicare eligible patients that were treated with axial vein ablations. And they found that these patients, Medicare patients, did just as well as non-Medicare or the younger patients. And this actually was presented yesterday by Peter as well. And yes, guys, life does go on. It is a good life. I know that it's been a rough year, a rough couple of years for us, I should say. But it's still good for all of us.
Assignment to try to tease out all those important papers.
Try to go as fast as I could.
Yeah. Next, we're going to have Marlin Schul is going to talk about stage versus simultaneous phlebectomy, the pros and cons. Marlin.
Thank you. Good morning, everybody. I remember Peter reaching out to me for this talk saying, I'd like you to review, staged versus concomitant management of saphenous veins and tributaries with phlebectomy. And I said, but Peter, since moving to Alabama, I haven't done a single phlebectomy. I love phlebectomy. Okay, that's one disclosure. But when patients are given the option, unfortunately, in our market, we've got that option. We've got chemical ablation services or phlebectomy. More choose to opt for chemical ablation. Anyway, I'm going to review the literature as it pertains to this, and let's get started. So the question really is phlebectomy necessary after ablation? Well, this has been looked at. So a friend of mine, Dan Moynihan, looked at a prospective trial of 45 patients, 54 limbs, normal deep system. You can see the SEEP variation there, did RFA ablation for the GSV alone and followed these patients for 6 months. The goal was to reassess symptoms and vein size of varicosities. 28.4% had complete resolution of the varicosities. 87% of the varicose veins decreased in size, an average of 4+ millimeters. And if you're in a market where you're needing to do your ablation first and then wait, you'll see these shrink. Okay, and in theory, you're going to have patients potentially change from being a phlebectomy case because they're gone from 8 millimeters to 3, and you're going to be then thinking about doing chemical ablation versus chasing those with a small scalpel. At 6 months, no phlebectomies were performed. In 39 limbs, patients had no additional treatment, meaning the rest of them had some form of treatment, which was chemical ablation in this instance. Okay, so it's been shown you can really defer AP if you have to, and a lot of patients see benefit with just GSV ablation. Well, let's look at another study. And this is where Hal Welch looked at 184 limbs, 146 patients, again, normal deep systems. 89% of these were symptomatic C2 patients, so a different severity compared to the Moynihan study. It was a retrospective chart review, and it was the GSV ablation alone through 3 months, and it was to reassess symptoms. Well, what they found is that 101 limbs, or 65%, had complete resolution of symptoms with or without varicose vein resolution. None had additional treatment in that group. 5%, however, led to delayed ambulatory phlebectomy. The conclusion of this paper was that there were a number of people showing that you get quality of life benefit from thermal ablation, and that it improves symptoms when you address the source of reflux. And so the question was, well, what would randomized trials show? Well, if you want to look and compare randomized trials, you want to look at systematic reviews and meta-analyses. And this is an example of a attempt at that. I think it's important when you look at the literature that you look closely. And when I say that, there's only 3 randomized trials in this meta-analysis. And if we take a close look, most of these studies involve general anesthesia, which we know 90+% of all vein care involves tumescent anesthesia with or without 70s and 80s music while the patient sings with you as you do their procedure. So, you know, if you took those general anesthesia cases away, then you can kind of look at the randomized trials that employ just tumescence and avoid the general anesthesia. So here are the 3 trials. You've got really 3 smaller studies, but nonetheless, they were randomized. Let's look at the first one. Well, if you look at this study, this actually was pulled up by this meta-analysis and another study that I'll show you in just a minute, and phlebectomy was not involved. And in fact, the study was, did it matter what distance that you treated with thermal ablation? And if you did treat and you treated the entire great saphenous vein, it was only looking at great saphenous vein, and you treated the distal with sclerotherapy, did it matter? This study shouldn't have been included, in my opinion, because it doesn't really answer the question about delayed versus concomitant treatment. So we won't spend any more time on this. So let's look at the next study. 50 patients, 39 completed the 5-year follow-up trial, 2 groups. The EVLT phlebectomy group, 1 in 25 needed a second visit over the course of the 5-year period. Of the delayed group, where you did EVLT only, 16 of the 24 needed a second session. Well, I think that's understandable. We're going to see some patients get complete symptom relief, and they're really quite content with where they're at after a single ablation. But a lot of our patients are going to need additional help. It's what we see every day. After 12 months, the progression of disease was equal in both groups. There was no difference in our RVCSS throughout the study. AVVQ lagged in the EVLT group through 12 weeks. That's because you didn't have the varicosities treated until after the 12-week mark. This is predictable, okay, based upon the study design. And the generic quality of life, there were no differences. So authors concluded that EVLA with either concomitant or sequential management remains acceptable treatment for symptomatic varicose veins, as both achieve excellent results at 5 years. So whatever you're doing in your practice, it's probably okay. You should basically think about what you're doing for your patient and make a decision with your patient. And that's what the next study shows. So you look at these authors, these are big hitters. Okay. So when you look at this, this is a randomized trial. They had 221 eligible patients. Okay. They were only able to randomize 101. And again, they staged or had concomitant treatment with AP. These patients had single axial vessels, either great saphenous or small saphenous with tributaries along that distribution. The primary outcome was quality of life by the AVVQ. The visits you can see here in the retention rate. The results, the reason they could only recruit 101 out of 221 patients is that 95% refused to participate due to a desire for a single session treatment. Does that surprise anybody? there is a desire for patients to get this chronic disorder treated in one treatment. And in many instances, it's just not practical. Primary outcome, 62% improvement in symptoms, both show significant symptom improvement at all time points. 6-week difference in quality of life was measurable between the groups, but that's because in the delayed group, there was no treatment until after 6 weeks. After that, in those patients that had delayed, only 36 needed additional treatment in the delayed group. I'm sorry. So one of the results here was basically the treatment decision. One of the conclusions here is the treatment decision should be between the provider and the patient when it's all said and done, whether they should do a combined treatment or whether they should do staged treatment. So now this is an effort of looking at the pros and cons. And again, we had a similar issue with study selection. And when you look at this, I think these variables are easy to see. If you're doing combined versus staged, they're talking about general anesthesia with single anesthetic. Well, that's a single anesthetic exposure is a positive thing if you're having general anesthesia. Single or few visits would be considered a positive thing. Ease of scheduling, if you can do it all in one session, patients don't have to take as much time off work. That makes sense. That's going to be a desire for many patients. Possibility of avoiding additional procedures. Well, if it's staged or not, I mean, that column probably didn't need to be there. Possibility of decreased magnitude of procedure. Again, I think these are common sense. Reimbursement, though, I think is a misnomer, because if you're having general anesthesia and you're having it in a hospital system, by definition, it's going to be more costly than what we do in our office-based setting, whether it's concomitant or whether it's staged. So there's bias in literature. Even though they looked at staged versus concomitant, a lot of times, well, actually, they all excluded sclerotherapy, but I demonstrated a study that they pulled in both of those that they actually included a study that had thermal plus sclerotherapy. So there's a study selection was actually weak in order to get an N. More than 90% of ANCARE occurs in an outpatient setting under tumescent anesthesia alone. This study looked at claims-based data in the UK, and they found that patients that had bilateral disease, those that had treatment in the popliteal fossa or the small saphenous, and those that had combined EVLT and phlebectomy were at higher risk of thrombotic complications. General anesthesia is unnecessary and is associated by nature with a higher thrombosis risk, and that's due to longer table time and delays to early ambulation as patients recover. Closing message: concomitant treatment versus staged treatment is the decision between the provider and a patient. Thermal ablation alone is sufficient for nearly 64% of patients, but we know that's not always the outcome patients are seeking. This disease state is labeled chronic venous disease or disorder, and attempting to complete all care in a single setting is often impractical, especially for advanced SEEP classes. Patients should be educated that even after successful intervention, additional surveillance and treatment may be indicated. We can't fix genetics, we can't fix hormones, we can't fix gravity. What we can do is improve the quality of life of patients and educate them on this disease process. I thank you for your time.
Thanks very much, Marlin. We're going to move on. BK Lau is going to talk to us about focus practice designation. What is it, and should we embrace it? This is an important topic that I'm sure he'll do justice to.
Well, good morning, everyone. This is my first visit to this meeting, and I have to say that I am amazed and delighted at the quality of the meeting. Just a little bit about myself. As part of my disclosures, I spend quite a bit of my time treating, thinking about, and researching venous disease. And as part of what I do, I also interface with the NIH, with the FDA, with Medicare and the VA in terms of how they're thinking about the way medicine is progressing. My practice involves working in an academic center and at a VA, and within this academic center, our division privately owns 3 outpatient practices where we perform our venous disease treatment. So one of the things I found fascinating is in the last decade is the tremendous explosion in new knowledge in medicine in general. We're transplanting pig hearts into human beings. We're injecting stem cells into the hippocampus of patients with Parkinson's disease. And what's delightful is that there has been a parallel matching explosion in the treatment of venous disease. And you've just heard this on the basis of the last 5 or 6 talks. Now, there are advantages and disadvantages when we grow. With growth comes increased scrutiny. And one of the things that I can tell you, the 2 largest payers in the country, the 2 largest payer systems in the country, Medicare and the VA system, are taking note of it. The volume of procedures to ablate lower extremity varicose veins has been increasing. And it has certainly caught the attention of pretty much everybody. And you can see that in these 2 graphs. The one on the left is just a simple compilation of 40 centers where the number of varicose vein registry entries have gone from 0 to 30,000 in 4 years. And in the Medicare system, this is only patients primarily 65 years of age and older. So not all the patients that we deal with. They're anticipating up to 600,000 vein ablation, lower extremity vein ablation procedures to be billed to Medicare around about this time. So a lot of growth in the field. Now, at the same time, about half of these procedures are being performed by surgeons, about a quarter by interventional cardiologists or cardiologists, and about a quarter by other specialties. And again, when you look at the Medicare records, there are about 44 different specialties that have billed Medicare for lower extremity vein ablation procedures. Nowhere in any other procedure has Medicare recorded this broad variety of specialties performing the procedure. And it's not good, it's not bad, but it's something that clearly has caught the attention. Now, the number of total procedures performed per patient is not necessarily a good or bad quality measure. And we're not here to discuss that. However, it is certainly an index of the broad variety of approaches that these different specialties bring to the table. It is a reflection of their approach to the diagnosis and management of the disease. And whenever there is such a large spread of approaches, it behooves us to try and understand what's going on. And what you can see over here on the graph on the left is that even though the mean number of procedures per patient nationwide was 1.6, it's a fairly large range. And the range is different by specialty. And when you look at the graph on the right, which is based on the Medicare reimbursement of procedures performed, you can see that the number of procedures per patient varies by specialty. And again, this is something for us as physicians and clinicians and providers to think about. Why is there this difference? So this, in summary, are the set of challenges in front of us. The number of procedures being performed for lower extremity varicose veins is increasing. And there's a large variety of specialists with a broad range of expertise that are treating patients. And there's objective evidence that there's variability in practice patterns. And this has come to the attention of obviously physicians, obviously product manufacturers, but now increasingly payers. And it's not going to be long before this becomes an important point of discussion among patients. So what has been going on in response to this awareness? So there has been an increased awareness, and various academic societies that represent us have been thinking about it and have recommended that there needs to be better defined appropriateness criteria and guidelines, and perhaps even increased accreditation to promote sound ethical practices as well as clinically sound practices in the management of venous disease. And these guidelines have been published, as have been appropriate use criteria, and they've been alluded to in the previous talks. But the documents are only as useful as those that read it. and those that implement it. And perhaps they're only as useful as the scope of each individual document itself. And this brings in the important concept of the need for accreditation. It provides a recognized authority in the certification process, and that helps recognize the practitioners as well as recognizes the practitioners in the eyes of government and funding agencies. It provides a stimulus for proper education for those that are treating patients, and it provides recognition for those that are dedicating their lives to the treatment of venous disease. And importantly, it provides a common pathway for standardization, particularly in an area where there are multiple specialties engaging in the same treatment modalities. And I would say that the current existing models, which would be the most logistically optimal way of approaching it, why reinvent the wheel? Why not just go with something that already exists? So, well, unfortunately, the current models cannot address this. We already have several accreditation boards, and they're not clearly performing at the level that we want them to perform. And none of the other bodies that exist, whether it is in the form of academic societies, the IAC or the ABVLM, none of them have the authority or none of them have a mission for the primary concept that we think we need, which is accreditation certification. So what have we done for this challenge that we seem to have recognized? We've recognized that there is actually a challenge. That's number one. That's a good place to be in. We've developed guidelines, we've developed appropriate use criteria, and now we're at the stage where we need to begin to explore the options for accreditation. Now, I had alluded to the tremendous explosion in medicine in general that has been occurring over the last decade or so. And you can see how, as our understanding of disease processes increases, this is only going to accelerate. The ABMS recognized this, and in 2017 introduced the concept of focused practice designation to acknowledge the fact that there are going to be new areas of medicine that will develop and emerge from within our current understanding of medicine. And the focused practice designation would be an avenue with which to try and standardize, accredit, and certify these emerging areas. And the level of review or scrutiny for such an FPD would be quite similar to that of a subspecialty. But logistically, it is impossible to introduce 100 other subspecialties, or perhaps even more than that, as medicine continues to evolve. And it is acknowledging this tension between the need to acknowledge and standardize emerging areas of practice versus the balkanization of medicine. They introduced FPDs. And they can be offered, and this is the unique feature, they can be offered by a group of boards, not just a single board. And this acknowledges the fact that there can be areas in medicine where multiple different areas of specialization or training streams can converge onto a similar disease treatment modality. So as I was mentioning, it allows physicians to concentrate their continuing certification efforts only to that focused area, regardless of which original board they came from. And most importantly, it is also agnostic to how the accreditation criteria are accomplished. It could be from several years of clinical practice, or it could be from a formal training program. And it acknowledges that people can arrive at that particular area of practice using different approaches. And the accreditation would encompass a measure of training, a measure of experience, and a measure of outcomes. And there have been now, as a result of that, over 17 or 18 such FPDs that have been approved, some sponsored by a single board, others sponsored by different boards. There's a minimally invasive gynecological surgery FPD, for instance, that has been sponsored by 2 boards and so on. The FPD in hospital medicine is the oldest one. It was the one that ABMS piloted, and it now has over 2,500 physicians already approved, with another, now I'm told, over 1,200 physicians that have applied. And it took about a year to get the application through. And those are some of the criteria listed at the bottom of the slide. Fairly concrete, fairly achievable though. So here's a possible FPD for venous disease. It could be divided into two levels. The first level would involve accreditation for people engaging in the diagnosis and evaluation, diagnostic testing, pharmacological therapy, compression therapy, wound care, and superficial venous disease. And a level 2 would include all of that, but also incorporate the diagnosis and management of deep venous disease. And possible criteria could include attestations, logs for patient encounters, log for diagnostic testing interpretation, logs for procedures, and of course, MOC testing. And I would actually conclude by saying that the time to act is now. Because if we don't do this, someone else is going to do it. People have already attempted to do it, and they will clearly do it in an imperfect manner, because those people are not engaging in the practice of venous disease treatment per se, and they don't have the patient's interests at heart primarily. Thank you all for your attention.